Hello, this is our Team 25 Nursing 517 project about reducing emergency department volume and improving patient care. Our team members are Alexis, Amy, Frank, Kim, Ambria, Vivian, and Brian. We would like to start by introducing you to the problem. There's been a change in the patient populations specific to the influx of immigrants and refugees such as Syrian and Somalians at Midwestern Hospital Emergency Department. The staff has verbalized a lack of understanding regarding the diverse patients and their basic and healthcare needs. Staff nurses do not have the ability to communicate with these patients because of a significant language barrier. They have limited knowledge regarding the values, beliefs, and preferences related to the immigrant populations, and the nurses also identified that they did not understand requirements of the insurers and payers related to their needs. In addition, there has been an increase in the use of the emergency department for non-emergent needs and staffing shortages in the ED as a result. This has caused an issue of increased wait times. Together, these issues have led to increasing discontent with both patients and staff members at the hospital. In order to address this problem, Team 25 Consultation Group reviewed the important issues and problems associated with the emergency department at Midwestern Hospital. As a result, they determined a plan of action based on Cotter's model for change in order to make the necessary changes within the organization. The consultation group recognized the importance of the 8-step process as discussed by Cotter in creating the changes necessary to maintain change. The team also recognized how important leaders and change agents are in buy-in of changes and therefore determined the action steps to help improve the staff perception of changes. Cotter's model includes the steps of establishing urgency, forming the change coalition, creating the vision, communicating that vision, empowering others, planning and creating short-term goals, consolidating and creating more changes, and institutionalization of these changes. The work plan for Midwestern Hospital Emergency Department, projected outcomes, advocacy, and future steps will be reviewed in this presentation, along with the examples and rationale for these important considerations. In order to address this problem, Team 25 has created a work plan using Cotter's 8 steps for change. We are going to begin by establishing a sense of urgency, which is vital to creating change. It must be recognized as a problem that is important enough to gain buy-in from staff members. Without having buy-in, the change process will be resisted and cannot be sustained long-term. Staff and leaders have already recognized and verbalized the important issues within the emergency department that are leading to these problems. Based upon the analysis of the information provided, priority concerns have been identified in order to facilitate the vision for changes. Team 25 consultation firm recognizes that one change will not likely bring about the changes necessary to improve all of the issues at hand. However, it is anticipated that the outcomes will be reached and recognized throughout our process. The coalition is important in facilitating changes as well. As the hired consulting firm, we find it vital to include the leadership within the organization and the important stakeholders in the community to help with the change process. Key members of the coalition will include the Emergency Medical Services Director, the EMS Nurse Manager, the lead EMS Nurse Practitioner, the Social Services Director, and the EMS Project Improvement Center Director. Additional persons involved in the coalition are the Social Services Manager, Board of Directors, and community partners. It is important that the leaders of the interdisciplinary teams are included in the coalition because they will be responsible for the implementation of changes that are pertinent to their departments. In addition, the consulting firm encourages the identification of early adopters within the interdisciplinary teams. These individuals could be helpful in obtaining information from the frontline workers on changes that are important, as well as leaders in the change process. It has been recognized in research that other types of individuals may be more likely to associate changes with positive regard if they have models of innovation acceptance. The third step includes creating the vision for change. Because the problems are comprehensive at Midwestern Hospital Emergency Department, the vision is multifold. It includes the development of a patient advocate role. The staff nurse will be trained comprehensively on the refugee and immigrant needs and resources available. This advocate will function in an educator capacity to help improve the understanding of patients regarding their healthcare needs. In addition, this individual will act as a liaison with community partners to help patients find pertinent resources in the community to decrease the non-emergent use of the emergency department. These resources include locations to obtain financial assistance for basic food and shelter needs, prescription assistance, health departments, and child services. In addition, the triage nursing role will also be modified throughout the change process. Because it has been recognized that there is a significant problem with the use of the emergency department for non-emergent needs, the triage nurse will function to determine the appropriate location and waiting room based on the patient's assessments and health history. Initially, part of the ED will be sectioned off into an urgent care portion. Over time, the expansion of an adjacent urgent care clinic will be completed. Patients will continue to enter through one entrance, triaged into the appropriate waiting room, and then seen in the appropriate location. It is anticipated that this will help to decrease wait times for patients who need emergent care and will also provide the health services that individuals need for their non-emergent issues. Staff buy-in is essential in creating a successful change. As a result, it is imperative that the vision is communicated effectively with input from staff and stakeholders associated with the change. In order to communicate the vision and obtain perceptions of these important people, a variety of methods will be used. These include in-person informational sessions that will be video recorded and put on the intranet for individuals who cannot attend the sessions as well. Intranet resources will be utilized by creating a change link that will have this informational session, bulletins, and updates regarding the changes. Within the change link on the intranet, there will be a location for individuals within the organization to ask questions and verbalize concerns at any time, with the option of providing information anonymously. Departmental and discipline meetings within the pertinent groups will also provide information regarding the vision and allow for two-way communication to address staff questions and concerns. In addition, town hall meetings will be conducted by change leaders to educate the vision to the pertinent and interested stakeholders and community partners. Because this issue involves care in the emergency department and the patient's needs in the community, it is vital to also answer questions and address concerns within these groups. Team 25 Consultation Group again recognizes the importance of teams within the change process. This includes empowering others to act in the change process, meaning that we are anticipating open communication within the community and organization to determine and address concerns throughout the process. Collaboration with the community will involve the important aspect of locating resources and building a team of participants in the change that can be used for referrals for the diverse patients being seen. In addition, experts in working with this population will be called upon to provide information that can be used to improve care geared towards the immigrant population. We recognize that it is important that staff obtain information regarding the patient's cultural beliefs, values, and norms. We also recognize the importance of addressing the language barriers between staff and patients. Based on the information provided from these experts, educators within the organization will be able to create free educational sessions that can be recorded for staff viewing which will help them to understand these issues when providing care. Training of the patient advocate will involve the immersion in the culture with an expert and collaboration with the educators and social services department to ensure that they can be successful in this role. The triage nurse will also be trained extensively to be able to effectively determine the appropriate location for the patient based on their current condition. Again, the intranet link will be used as an important reference to help individuals within the organization locate appropriate resources and materials needed to provide effective patient care. The short-term goals include the piloting of the patient advocate and modified triage roles, with a part of the emergency department being sectioned off for non-emergent care needs. During this time, the advocate will be used for 40 hours per week. During the time period, which will be Monday through Friday, that has the highest ED patient volume. Data will be collected and compared with pre-change data to determine if the change is effectively meeting the organizational goals. Over time, the advocate role will be expanded to all hours on all days, and new construction of the urgent care waiting room and clinic will be completed. When consolidating the changes, the urgent care staff will be relocated into the urgent care new construction area. The staff in the emergency department will be cross-trained for both the urgent care and the emergency department sections. This will facilitate the team process within the two patient care areas and could improve staffing by floating staff to the locations that are busiest during the day. Additional staff, including more patient advocates, nurses, and physicians, and nurse practitioners, will be hired to ensure staffing in both sections are safe and effective for addressing patient care needs. Also, during the consolidation process, it is important to recognize that some immigrants will be admitted to inpatient units. As a result, there will be additional education necessary to help improve care within these areas. This includes the provision of additional education based upon the patient's basic care needs and beliefs. It will include collaboration with the interdisciplinary team to ensure that appropriate translation services are used, appropriate and acceptable food choices are offered, and basic values and beliefs are addressed while patients are on the inpatient units. It is important that the changes made are institutionalized into the culture of Midwestern Hospital. To achieve this, information and data will be presented at the yearly staff meetings regarding the change process and the identified outcomes. This will help to ensure that the changes are recognized in their importance and impact on both patients and staff members. In addition, it will ensure that the changes are maintained within the organization. Information will be disseminated by continuing to use the link on the intranet so that questions and concerns can be visible to determine additional changes needed and improve outcomes. The training developed during the change process will be integrated into the new hire training and will include information pertinent to the location of hire for the new staff members, whether that be the ED, urgent care, or inpatient units. This will help to ensure that all staff members are aware of the policies of the organization and knowledgeable about the resources available to them and their patients. Additional hiring and cross-training will also be important to ensure that staffing needs are met in the hospital to help patients receive the appropriate care. Based upon the patient flow and population needs, an assistant manager may be necessary for the emergency department, urgent care department, or the hiring of an additional nurse manager for the urgent care area. Team 25 has identified 5 outcomes with measurable metrics to ensure efficiency and quality of this change implementation. Previous hospital data will be used as a baseline. First, the wait time until provider encounter will be reduced to less than 30 minutes within 3 months of change initiation. Second, the percentage of patients who leave without being seen will be reduced from 10% to 5% within 3 months of change initiation. Third, an annual staff satisfaction scores will increase from 70% to 80% within 6 months, and then 80% to 85% within 12 months of initiating the change. Fourth, emergency department patient satisfaction scores on the HCAHPS survey will increase from 60% to 80% within 6 months of initiating change. Lastly, patients seeking the emergency department attention for non-emergent needs will be reduced by 75% within 6 months of opening the urgent care clinic in January of 2020. Our team expects these changes to decrease morbidity, improve quality of care, and increase financial revenue. Research indicates that staff satisfaction is linked to shorter wait times, staff retention, and quality of care. Left without being seen rates with contributing wait times are quality metrics reportable to Medicaid and Medicare services, which could affect reimbursement. The redefinition of quality by the Affordable Care Act has been linked to HCAHPS scores, has linked HCAHPS scores to financial remuneration for services. Finally, ER misuse is statistically higher in a lower socioeconomic population. Enhanced emergency department services and the development of an urgent care clinic will effectively serve our influx of immigrants and refugees as well as our ever-changing population. In order to meet our outcomes, Team 25 has developed a list of deadlines. First, organizational transparency of the emergency department efficiency and quality, as well as changing needs of the growing population, will be discussed in a mandatory staff meeting. This meeting will include team building via informal relationships, and a healthy culture will be promoted. The meeting will be completed by August 1st, 2018. Next, the organizational hierarchical structure will be complemented with a multidisciplinary team that promotes innovation, altruism, and a volunteer network. This team will be formed by August 28th. Thereafter, the social justice, financial impact, and organizational vision will be developed by the multidisciplinary team with defined outcome metrics by September 5th. Then, this vision will be communicated to identified intra-organizational and community stakeholders. Participation opportunities will be publicized via social networking, community events, and recruitment agencies. This will be complete by October 2nd. Continuing forward, interprofessional collaboration and education opportunities will be offered via workshops and continuing education units. These workshops will be developed by October 30th and will be offered 4 times over the course of 3 months. Outcome metrics will be measured and displayed monthly via intra-organizational emails and unit bulletin boards with a staff recognition program utilized. In addition, the dual operating network of organizational hierarchy and multidisciplinary teams will attend monthly meetings that promote innovation and celebrate staff contributions. Finally, the nursing professional development specialists will incorporate the changes into mandatory staff education as previously discussed. This will be implemented after the hopeful success of the project in February of 2020. Team 25 will also recognize the importance of advocacy throughout this implementation of this project. Advanced practice registered nurses and other healthcare members will advocate for a primary care clinic that manages the healthcare needs of newly arrived immigrants in the local community. In addition, these APRNs and other healthcare providers will advocate and support legislature at the local, state, and federal levels that will help address social factors which can help to alleviate health inequities and inequality among newly arrived immigrants in the country. APRNs will also petition to be recognized as primary care providers servicing immigrants and thereby should be reimbursed for healthcare services provided to this vulnerable population. Through advocacy, nurses will engage in socio-political issues that may be affecting the health of the community with the arrival of the immigrants and refugees, including those from Syria and Somalia. They will also be champions in leading health fairs and education forums in the local community to educate these refugees. In order to continue to serve vulnerable populations, APRNs will form coalitions with local churches and schools with a population of Syrian, Somalian refugees or populations in need that are in attendance, and to provide education on childcare, childhood immunizations, nutrition status, and housing needs. Nurses can advocate for interpreters and translators to be available at every health clinic in the community to address any communication needs that may be a limitation in accessing healthcare among vulnerable populations. It is also important to acknowledge that nurses will be at the forefront of advocating and providing testimonies for these vulnerable populations. They can provide these testimonies in Congress about the care that they provide to vulnerable populations, especially the immigrant populations, so that federal programs such as Medicare and state programs such as Medicaid can be expanded to incorporate reimbursement for APRNs. Nurses can use social media channels such as Facebook, Twitter to expose the needs of the newly arrived Syrian and Somali refugees in the community as a way of rallying support and assistance for this vulnerable population. They can also use these channels to promote and educate the population about the importance of using nurse-led primary care clinics for health issues that are not an emergency situation. Another way nurses can use social media platforms are to start a conversation with community leaders, local health providers, physicians, lawmakers, policymakers, and so on about the recent health needs of the community with the advent of newly arrived refugees. and devise a collaborative approach through which the healthcare needs of these vulnerable populations can be addressed. In recent times, social media has become a powerful vehicle in bringing about social change through the rallying together of so many voices for a common cause, especially when the vulnerable of society are concerned. Thus, advocating for the vulnerable populations by nurses using social media will gain swift responses from several politicians. Nurses can also take lead in vulnerable population health needs by writing letters or calling their local representatives at various levels of government. In conclusion, Cotter's model for change was a very suitable model for our case problem. It allowed us to take the necessary sequential course of action that gave us the best chance to achieve our desired outcomes. The model structure made it feasible to lay out each of our proposed solution steps within each of Cotter's steps. Our next steps include modifying our original plan as needed based on staff and patient feedback. Team 25 would also consider publishing this work plan and the use of this model into professional journals. Furthermore, a final recommendation for this project would be dissemination of our work plan and steps into other emergency departments that may be experiencing similar issues, such as an influx of immigrants and vulnerable populations. Here is a list of all of our references. Please post on the discussion board if you have any other questions, and we appreciate any feedback that you have. Thank you.